Very excited to have everyone here for the latest webinar, The Power of Supporting Mental Health at Work. Today we've got a very, very special host, Stéphane Grenier. Stéphane is founder and lead innovator at Mental Health Innovations, keynote speaker, and a former Lieutenant General in the Canadian Army. At Mental Health Organizations, Mental Health Innovations is an organization dedicated to assisting workplaces in implementing simple and tangible solutions related to mental health. They support corporate leaders looking to move beyond traditional methods of care. Stephane spent much of his career redefining how workplaces and individuals should care for and support those affected by mental health problems. He has a non-clinical approach that offers managers and leaders simple and pragmatic ways to encourage their teams on the path to wellness. Today we're going to try and be respectful of everyone's time, so Stephane is going to be taking everyone through this presentation at a high level, but if you do have any questions, feel free to reach out. Again, you can ask them in the chat, or feel free to reach out to us at League or Stephane once we're all wrapped up. So a little bit about League. We empower employees to live happier, healthier, more productive lives through a suite of health and wellness benefits that they actually want and will actually use. What we've learned, we know that benefits are only valuable when employees truly feel empowered to actually use them. So we've tried to reimagine health benefits. League is consumer-centric, preventative, personalized, and always on. We give your team benefits and insurance to address their health and wellness. We do this through spending accounts. These are health and lifestyle spending accounts that give your team the flexibility to spend their dollars and spend them on eligible expenses however they choose and on what's important to them. We also have Health at Work that lets you, the employer, bring health professionals into your office for sessions like seminars, clinics, to help your team be healthier. And lastly, we offer a Peace of Mind plan. This is an insurance plan that covers your team for basics like life or accidental dental so they can rest easy. In the end, we just want to be able to make life easier for your team. We do this by offering flexibility and choice. Your team members can choose how they want to spend their benefit dollars based on what's important to them. And as employers, you get unprecedented control over your plans by offering a combination of insurance, spending accounts, and Health at Work to match your needs and budget. Employers also get financial control. With our benefits, you only pay for what gets used. And that means you get a bit of certainty, allowing you to effectively eliminate any year-end expenses that may come up. Our health marketplace is a place where your team can choose from a network of thousands of health providers and services that they can book, browse, and pay for all through the League app. And lastly, we offer a digital experience. Employees use the League app for everything to do with their benefits, including paying for and submitting claims through their digital wallet. And as employers, you get to say goodbye to forms. So all administration with League is done through our online portal. So before we dive in, just a reminder, if anyone else has joined, please add any questions that you might have to the chat. And I guess without further ado, I want to pass it along to Stéphane Grenier to take us through the power of supporting mental health at work.
Thank you very much, Brian. Thanks for the opportunity to connect with all these folks. I'm going to, as Brian alluded to, take you through a bunch of topics here at fairly rapid pace. Consider it going wide and not too deep, but we're certainly happy, League and myself, to re-engage at a later time if any of you have more questions than we can answer today. On the first, on the introduction to this, I'd like us to look at the scale from 0 to 10 and imagine a world where we rate stress on a scale to 0 to 10. 0 being an employee, one of you maybe, who has zero stress in their lives. In other words, you're happily married, you've got a great partner, you may have children and they're wonderful kids, you have a dog, no debt, great boss, great employment. Essentially, your life is perfectly balanced, and arguably, rare are the people who live in that zone, in the 0 zone of absolutely no stress. If we look at the other end of the spectrum on the 10, the top of the line, is unfortunately where I found myself in at a few places during my journey. And this was literally, in one instance, in the garage with a rifle, trying to figure out the angle within which I could actually commit suicide and not miss. Now, I'm not saying this for any other reason to say that it is a reality. It's not a daily reality for many people. But again, making the point that rare are people like us living in the 0 or living in the 10 zone. And I say this because we live our lives, either in our families or at work, on this spectrum between 0 and 10. Hopefully none of you ever feel like or know what it's like to be a 10, and hopefully you all manage to figure out how to stay in that 0. Reality is we ebb and flow on that scale of wellness. And throughout life, things happen. I remember when I had my firstborn, David, crying a lot at night, and many of you are parents, I'm sure, and you've had that experience of getting up in the morning, and in my reality, I was getting up at 5 o'clock in the morning, going for physical training with my troops, and with not a great deal of sleep during the night before. And many, many months later, one of my fellow coworkers said to me, Stephane, you really look tired today. What's going on? And for some reason, it felt okay for me to respond to that and engage in a dialogue in a workplace where I responded to his, how are you, and you look tired, and we had a chit-chat about that. And I remember him at one point saying to me, hi, Steph, I had a child a few years ago too, and I went through this. He said, try to put the baby, on the dryer and start the dryer, and it'll shake, and it's a little warm, and baby will feel better. And he made a joke, and he said, don't put him in the dryer, put him on the dryer. Anyways, we were having a very authentic, meaningful conversation. These were two guys in the 80s around a baby not sleeping. And arguably, I make this point because arguably me not sleeping was not a problem in the knee. It wasn't a heart problem. It wasn't my pancreas acting up. It was a mental health problem because I was tired. I was a little cranky or whatnot. And so looking at mental wellness now, we need to look at the complete spectrum. And if I were to say where this would land on a scale of 0 to 10, it was certainly not a 0, but it wasn't a 10 either. I would put it at around a 3. I can give you multiple examples of life situations. You can come up with dozens of these situations, and you sort of place yourself on the spectrum. Now, of course, this is a slide to make a point, and the point is that I believe that we rarely engage as human beings, even in our families, even with our closest friends sometimes. We rarely engage in what I feel is the 7 to 10 zone. And the 7 to 10 zone for me in this piece of work is all about when you go beyond a certain point of ill health and you're really having a hard time going back down on that scale. And for those of you on this webinar, you're motivated to come on this webinar to know and learn what can we do to, these are my words now, keep our employees below that 7 zone. Because when they get into that 7 zone, we don't know what's going on. We know they're seeing a doctor. We don't have any information. Very awkward for us to support them. And for me, the 7 to 10 zone was when I came back from close to 11 months in Rwanda during the 1994 genocide. For me, the 7 to 10 zone was one particular day when water started coming out of my eyes. For no apparent reason, in a very busy workplace, an operations center with things happening all around me at National Defense Headquarters, I'm in uniform, and water starts coming out of my eyes, and of course I retreated. I went to the bathroom, put water in my face, reconstituted myself, and came back. When I came back into the operations center, one of my colleagues said, what's wrong with you? Your face is all flush. What's going on? And I blamed allergies, of course, because this was the fall, and I thought I was like a child on the kitchen counter with his hand in the cookie jar caught by mom. And for a fraction of a second, I was so embarrassed that this individual, a colleague of mine, may know why my face is flush. And of course, I did not feel comfortable in speaking to him, or anybody for that matter, regarding what had just happened to me, because I certainly didn't understand what had happened to me. And that exemplifies, I think, the ambiguity and the uncertainty of a situation that you're not even sure what's happening to yourself. Some colleagues might be reaching out, but you're not being truthful with them because you're in fear. That was not the case years before when David was born. when I was in the zone, but I was in the 2 to 3 zone perhaps on this scale. And it was okay to have the conversation. And by the way, I got a few tips and we joked about it, and I felt normal. I felt like I wasn't the only parent going through this struggle. And I'm sure many of you, if not all of you, have gone through similar situations. So the point of this webinar, the point of this whole service offerings that we're trying to re-engineer and change the way workplaces deal with mental health is to make it a lot more normal to accept that we are human beings, we have a brain, and it's almost unheard of to think that the brain is immune to illness or injury. And so as we move forward, I'm resetting, if we can, some of the paradigms, and I'll get into that in a second. If you look at this slide here, the point I want to make is in 1994, when I went to Rwanda, was really a big turning point for me, because at that point, I became pretty ill. And arguably, you can see in 96 period all the way to 1998, I was kind of addicted to adrenaline. And I think that in other workplaces where this is very relevant, some people turn into workaholics. Well, this rapid series of deployments for me is the civilian equivalent of becoming a workaholic. In other words, you're always in the fray. You're always volunteering for all sorts of things, and or you're working like a mad person, and you just keep going. Now, I had been diagnosed in the early years after Rwanda, but I completely refused the diagnosis. I thought I was just fine, but I got re-diagnosed in 2000. Despite that, I went to Afghanistan in 2007, and I carried on, because I contend that while I maintain that I'm still a patient today, by the way, I still see Dr. Peter Boyles at the Ottawa Civic Hospital, I still take my medication, but I believe that while I'm still a patient, I'm fully recovered. And by the way, I'm not the only one to believe this. There is a lot of evidence around the recovery model, the recovery philosophy, that not unlike a lost limb, and I do have permission to speak this way from people who have lost a limb, when you lose a leg, that leg will never grow back. But it is possible to perform, it is possible to lead a relatively normal life if you're just equipped with the right prosthesis. And the right prosthesis, the psychological prosthesis we human beings need, are clinically driven, but this webinar will hopefully give you a few tools on how to complement the clinical prosthesis to make it a full functional prosthesis, because I do believe workplaces are part of the solution here. So let's look at a few paradigms, and let's look at shifting those a little bit. The first thing that I would encourage all of you to do in your respective workplaces is, and of course we can engage more on this after this webinar for those of you who are interested, but I really encourage you to build an organizational narrative around mental wellness that is excluding the clinical terminology. I coined the term many years ago, stress injury. The reason why I coined that term is because I fundamentally believed that we as lay people, and I say we as lay people, the non-doctors, and remember, I am 4 doctors. I work with a psychiatrist and an occupational health specialist. But we don't live in our doctor's offices. Your employees struggling today with mental health problems don't live, work, breathe, and sleep in their doctor's offices. They live out there. And we need to create an organizational culture and even a Canadian society where we just admit to ourselves and we are okay with the fact that the same way you can trip on a rock or on your shoelace and sprain an ankle, the same way, and that's life, the same way life can trip you up and you can figuratively sprain your brain. And when you have a sprained brain, of course, it is not a real term, but it's a figure of speech, you're suffering what I call a stress injury. And how do you bounce back from that now? So right now, the narrative that sort of infuses the way we shape and the way we deal with workplace mental health problems is literally shaped by evidence-based, clinical practice, diagnostic language, and symptom-based education. And I say we need to shift away from that. All of this is extremely important for all the great therapists out there and the pharmacologists and all of that science to actually treat the mentally ill. But there's a point well ahead of developing a mental illness that we, the lay people, need to recognize and support each other when people have sprained ankles, sprained brains. Imagine if everybody who ever sprained their finger, their wrist, or their knee, or whatever, went to the hospital. And that is literally what's happening now. And we wonder why our mental health system is so saturated. When we look at the term stress injury is born out of 4 causes. They can be combined, they can be independent, and remember now, this is a concept that is outside the diagnostic range. This is not meant for doctors, although a lot of clinicians nowadays are referring to the term I coined 17 years ago, stress injury, but that's nor here nor there. The first cause of a stress injury is considered trauma. And of course, I don't want to get into trauma too much. We can get into this for those who want more information, but I think we understand the concept of trauma. The second is fatigue. And that I will quickly, again, we're not going deep, we're going wide here. The concept of fatigue is the cumulative wear and tear on people over time. This is not, I watched a hockey game and went into overtime, I went to bed late and I'm tired today. That's tired. Fatigue is to do more with less, a lot of overtime, and that cumulative wear and tear on people. Grief is the sense of loss. Now, grief can be associated to death, but often it comes outside of the experience of death. And the best example I ever got for grief from an individual who was not from my past workplace was a very nice lady who told me that that's what I got. I went through this. In other words, she gave me a great example. And she was working for a law firm in Toronto, and she said to me that for years, for about 7 years, I think, she was working for the greatest boss ever, a lawyer, open door policy. They had a great team. Everything was great. She said, I used to look forward to Monday mornings to go to work. And then, she said, he got promoted, went up to the 56th floor, the 46th floor, and somebody else came in his place, and it was a complete opposite. And I grieved. I was upset. I did not want to go to work I felt I didn't fit in anymore. Now, that does not mean that she became depressed and she started taking medication and she had to go on sick leave. But she had experienced the sprained brain. Her brain wasn't functioning the same way it does every day. And so, and she never said whether or not she developed depression or not, but that was so important for me to see that this phenomena of stress injury transcends pretty much all workplaces. I'm sure you can come up with examples of your own as well. Moral conflict. The moral conflict piece, again, in the spirit of time, is best explained by the fact that each and every one of your employees, although they abide by the code of conduct of your organization or they believe in your vision, mission, statements, and all of this, doesn't matter. Fact of the matter is, each employee brings in a slightly different moral compass into work every day, slightly different. The big things, the morally right and the morally wrong things, the big things we sort of all accept. But it's the little things that really grind at people when we're asked to do certain things or not do certain things. And I'm sure there's a bunch of folks in the HR sector here on this webinar, and I do remember talking to so many HR practitioners out there who were up against huge workplace reduction exercises where so many people were being laid off, and at the end of the day, they just did not feel good. And so that may be an example that might be relevant to explain moral conflict. And so it's either when we're asked to do something that really doesn't sit well with us, or conversely, something we can't do that we would rather do. So again, 4 causes very rapidly, but I think it's important, especially if there are first responders on the call, and I'm not sure if there are, but we focus so much on trauma that it almost gives other people who weren't traumatized no reason for decompensating or experiencing mental health difficulties. And I say we need to move on from that. It is very important to just accept our human condition for what it is, and our brain is no more immune to injury than the rest of our human body. And again, the 4 causes. Now, what's what I believe is the primary source of solutions for many workplaces, and I don't know which workplaces you all are from right now, but nor here nor there. The big push over the last decade or so or more has been to provide more robust clinical services, mainly through the conduit of an employee assistance program. And that is absolutely a great thing, ensuring that your employees have access to a few sessions, half a dozen, 8 sessions, to help them when they're struggling is certainly not a bad idea, and we need to continue to do that. And while this is true for workplaces, we need to continue to grow and nurture the clinical capacity in this country and ensure that Canadians have access to the best mental health care they can. Insurance plans now cover better medication and extend coverage to new techniques and new ways of helping people cope with stress, and that's all good. Ask yourselves, however, what happens between those medical appointments? And this picture might be a little dramatic, but it illustrates how I felt myself and how so many Canadians will be feeling tonight after their day at work. Not because they have a really tight deadline and they're overwhelmed, but because they're not well. They may have a stress injury. They may be struggling right now. And for those who are struggling, who call the EAP and have those sessions, we need to ask ourselves now, what happens between these clinical appointments? And for those of you interested in reading my book coming out in 2018, I do talk about, briefly, my 4 suicide close calls. None of those 4 suicide close calls were in my doctor's office. Never. People rarely commit suicide in their doctor's office. And I don't want to make this overly dramatic by focusing on suicide all that much, but that is the ultimate price that somebody pays when they're not supported and they're not treated properly. So the gap between clinical appointments, I think, really needs to be looked at, because people can recover from a broken leg without supports, apart from crutches perhaps, but the support of others. Signing the cast when somebody has a broken leg, like we used to do when I was in high school, helps. You know, it's cool. You feel like, hey, I got a cast. I'm a popular guy now. But that leg will not heal faster or slower, dependent on how many signatures you have on that cast. But this is so untrue for mental health problems. The more support you have, the quicker you reestablish and regain your health. And that is very, very much in contrast with physical health for many reasons. So one of the studies I like to present here, and if you look at the bottom, the source is there, and you'll look right away and you'll say 2000, my God. If you go on my website, MHI website, you'll see a Dr. John Richardson there. He's a psychiatrist who's done his whole career in of course, mental health and trauma. And he will tell you that this study has not been contested and it's still as valid as the day it was published. So I keep using this to make the following point. This is a study that looked at the risk factors. In other words, not unlike physical health problems, like lung cancer as an example. Well, we kind of do know now that if you smoke heavily, you're more at risk than perhaps a non-smoker of developing lung cancer. So risk factors are also true of mental ill health or mental health problems. And this study looked at a bunch of factors, some of which made it to the slide because they were significant enough, and so many others weren't statistically significant, so they did not make it to the slide. If we look at this in the context of my own example, psychiatric history. Well, I'm sure that when I came back from Rwanda and I wasn't really myself and I was visibly struggling, people might have asked themselves, I wonder why Stephane is so tormented now that he's come back from Rwanda. I wonder, maybe, just maybe, when he was a teenager, he had a bout of depression and went on antidepressants for a while. And if we had known at his workplace, we might have not sent him to Rwanda, where this place was terrible. And so psychiatric history is a risk factor. In other words, if you go through a lot of hardship and you have a psychiatric history, you're more at risk than somebody exposed to the same hardship who does not have a psychiatric history. Same for childhood abuse. So what if Stephane was beaten up as a child? Unbeknownst to us, we send him to Rwanda, poor guy. It brings back memories from the past. So all of these are actual risk factors. Trauma severity is a risk factor, but if you look to the right, the lack of social support is the most predominant risk factor that will indicate who is more likely to struggle and develop a mental health problem after hardship. So we have to ask ourselves, what are we doing about that? This is the kind of evidence, folks, that rarely makes it in the New England Medical Journal. But of course, it doesn't mean that it's not valid. It just never makes it on top of the pile. It certainly made it on the top of the pile for me 17 years ago when I implemented my first peer support program, workplace peer support program, because it makes so much sense. So if the lack of social support is the most predominant risk factor, what are we doing about it? Well, I say we inject an antidote to that. And what could be that antidote? So by doing that, by actually empowering social support to grow in your organization, you're adding a layer on top of that clinical intervention. So look at that scale of 1 to 10 now flipped on its side, where 1 is the complete left, healthy zone, the green zone, the zone we all want to be in. We want to be at the tip of that arrow, and the 10 on the complete opposite in the right there. And so as we provide more and more robust clinical care to people who are sicker and sicker, we also need to include more social support in order to foster their recovery. And so how do we do that? So I will say to you that from my experience, and if you were to Google the recovery model or the recovery philosophy, you'll see that the Mental Health Commission of Canada put out recovery guidelines. So the word recovery here is not just a pretty word. It's a word that has a lot of meaning and strength in the mental health world right now. Why? Because we realize that for recovery to occur, there are many, many similar pathways to recovery for mental health than there is for physical health problems. However, there are very unique pathways as well. So the ones that are common is therapy and medication, but social support is seen as that third leg to that three-legged stool. So as you approach mental health workplace, I think you really need to keep this three-legged stool image in your mind and imagine what it's like to sit on a two-legged stool. That's pretty shaky. It's still relatively stable, but without the social support element, you're really missing a key part. So what can be done about that? So I think some of you are probably joining the webinar because you really want to know what do we do here. Well, I'll tell you what you see in front of you now. I would encourage you to perhaps slow down if you're doing this. I don't think workers, employers, employees should be focusing on more stickers, more pamphlets, more fridge magnets. Bell has talked a lot about mental health in the workplace, and this awareness is certainly taking us to where we are now. But what I say for all of what talking has done, it's now time to certainly walk the talk. So what can be done to actually walk that talk? I think the thing you need to remember is what I'm presenting today is based on what we know works. And of course, we don't know it all, but what we do know works, we're sharing with you today. We've decided as a fairly small company, but a growing company, to focus on things that are not currently done in the mental health workplace industry. Not that we want to use our clients and their employees as guinea pigs, but certainly act as evidence-based as we can, not use people as guinea pigs, but not simply replicate and cut and paste the proliferation of current services. So the first thing is, I think, depending on how long you've been on this path of trying to improve workplace mental health, reduce those grown statistics of long-term disability, and whatever's motivating you, look at what you've done so far, and then look at what you have not done yet, and think outside the box. So I'm presenting here today very rapidly three things that I know works, that has worked for everyone we've worked with, and really presenting those to you for consideration. So the first element is there's so much attention put right now to training our workforce, training our managers. And as we move forward in that, and I don't think that's a bad idea, but what I do think is the training needs to come to fruition in a slightly different way than many of the training curriculums that I've seen. So far we've created, I think, a really good baseline, and I think there's a pretty good understanding around, healthy dieting, and I think these are all instrumental in ensuring that the baseline is there to move forward. So eating a healthy diet, sleeping, a good night's sleep, get your 8 hours, hydrate a lot, drink lots of water, and exercise on a regular basis. And, of course, employee assistance program, good insurance plans, and those things need to continue to be the focus. But what else can be done, of course? So when we train people, I would say that I don't think that in 2017 people need to be, literally trained and spend time with an expert to tell them that an apple is better than a piece of cake and they should sleep 8 hours a night. So I think we need to be more creative than that, and we work to enhance what we already have. So what I will focus on here are 6 elements that certainly need to be focused on. Now, you're going to wonder what this first one is all about. It is really born, this sort of principle, this basic principle of mine and at MHI is born out of the fact that we're often approached by folks who want to join our team, and when we interview them and we talk to them, we realize that their philosophy certainly doesn't align with ours. And I remember years ago, a very, very popular mental health trainer in Canada. We're thinking of maybe working together, and the philosophy certainly didn't align because she approached the whole training curriculum as we need to provide people and managers with the tools. And my philosophical approach is completely the opposite, where I say, no, they have the tools. They just aren't using them. Because to me, recovering from a mental health problem and the support we need to provide a person recovering from depression or coming back to work is no different than when I came back from the funeral of my father passing away, and I came back bereaved, and you know what? My colleagues acted perfectly fine. My bosses said all the right things, and I felt supported. Why can't they do the same thing when I have a mental health problem? So you're going to think, well, what's the point? The point is, the philosophical approach of whoever you put in front of your employees has to be that you guys in front of me now, the classroom, you're not kids. You've done this before. You've done it your whole life. But somehow something happens to us when we're faced with an employee with a mental health problem, and we think that those things we say, we can't say now. And so we need to simply remind people of what they're capable of, as opposed to providing those parochial tools to have the conversation. The second point is I firmly believe that the World Health Organization is completely right when they say that if you need to resolve complex health-related issues in a complex system, the only approach that can work is the community-based rehabilitation approach. The term is CBR. And in essence, you need to engage your workforce in identifying those areas of greatest concern. If you try to train everybody on everything under the sun around mental health, you're basically achieving very little. So, in other words, engage the people. It starts with them. Determine, and we do that, determine what the key areas of concerns are, and then ensure the curriculum is tailored to those needs, as opposed to assuming the cookie cutter mental health in the workplace 101 is going to work. It's not going to not work, but it's not going to work either. And so number 2 is really engage your workforce. And by engage, I'm not saying review last year's engagement survey results. No, I think you need to be really focused and engage them based on understanding what their needs for more information is. The third point, I think very, very important, and we could use the term emotional intelligence, but essentially it's too late for the manager to be seen as caring about the employee's wellness only once the mental health problem or the stress injury starts appearing. We need to create an organizational culture with our clients. You need to create that culture, that leadership climate, that management climate, where these managers care for their employees regardless of if they're sick or not, but that relationships between managers and employees is built well ahead of any problems emanating. Without that key element, very, very difficult, the analogy I use, very difficult to teach a person how to swim when they're drowning. We need to go upstream and create those relationships before. And it's very possible to build very solid, robust relationships ahead of time. The next point is human-centric culture, not a clinical one. And that speaks to the point I said earlier, change the narrative. And so move away from a symptoms-based narrative. Talk about behaviors, not symptoms. Very similar, very different. I really encourage you all to, if you do want to offer training for managers because you think that they need more information, don't ignore the frontline employees. Create an opportunity for the entire workplace to evolve, not just managers. And finally, very important point, teach people that listening, building that relationship is more important than solutions. I believe that so many people are really stressed about having a conversation with a depressed employee because they think that they need to come up with solutions. Authentic, caring, and building a relationship of trust is half the solution. So again, very quick here, but these are 6 important elements on how to pick the right trainers and how to pick the right approach for you. The next piece is, I'll go very quickly over that, is how to create a peer support network for your organization. And again, this addresses the social support needs of your organization. These folks are a series of about half a dozen barriers to why these initiatives have not really taken off. Because of course, we don't want to, think that people who had a mental health problem 6 years ago, well, they're fragile, How do we know they're not going to do harm? Is there evidence? Well, yes, there is evidence, by the way. What about the liabilities? Well, if you build a solid program with strong policies, your liabilities are addressed. Is there expertise in the field? Well, I can speak for ourselves. Yes, there is expertise in the field to help you build a program. And then what about the complexity of implementation? Well, compared to building a house, if you're not a home builder, it's complex to build a home. If you are a home builder, it's not complex at all. So again, there are now solutions to all of these sort of barriers. Again, quickly here, peer support in the workplace is not clinical care and it's not friendship. It's that sweet spot in between. And it's very possible to create a program and empower dozens of currently paid employees to volunteer as peer supporters and stay in that sweet spot if you do it right. This is a typical implementation blueprint that we use when we implement these programs. And you'll see at the tail end there on the right-hand side, there's training, but training is the last element you need to be concerned about. In the middle there, that policy development is huge. And when you start right after planning, engagement, and consultation. Why? Because you need to tailor the program to the needs of that particular workplace. A Canadian invention, folks, the standard of practice for peer support, the competencies. Very important to have a psychometric, defendable way to pick the right people to do peer support. And so without those behavioral indicators of competencies, you might be picking the wrong people. And past programs who have failed, it's because mainly they did not have policy and they did not pick the right people. So if you do launch a program, what can you expect? And I think this PowerPoint is available later on, so I think you don't need to cover all the stats here. But what I will show is that the bottom here, you'll notice that in one of our clients, 55% of interactions happen outside of work. And for those 45% remaining that occur during the workday, close to half of that is done during lunchtime or breaks. So there is no great fear out there that these programs will reduce operational outputs and key performance indicators. A few case studies. These are some of the results. The size of the organization here, just over 1,000 employees, and what they've noticed. These are reported by clients, and so sort of that reduction on short-term absence is important. This client here is a little bigger, 6,000 employees. coast-to-coast organizations scattered across the country. And you can see a 15% reduction and a non-measured reduction, but on long-term disability and short-term is at the 15%. And so my question is, and I still don't have an answer to that, is what is a reduction of 15% in value, in dollar value? We're going to close off, folks, on culture. There's a lot of talk nowadays about culture and, the culture of the organization. If we could just change the culture of the organization, things would be better. And the approach that MHI uses is a very solid but very pragmatic theory and practice of moving your culture to one of efficacy and one of support. And so, people tried. They get together. If it's an unhealthy culture, they get together and perhaps focus on the wrong things and pick on people, and there's a lot of gossip. And so our sort of approach to this is based on a very, very solid model, tribal leadership, which talks about the fact that in any organization, if you had an organization of 100 people, you would have in the middle there about 50% of the people who would probably come in at stage 3. So this is a 5-stage sort of fragmentation of your organizational culture. In your typical organization, you'll have roughly 50% who are people who are dominating, who say, I'm great and you're not, and I'm the boss and you do what I'm told, you do what you're told, and this is sort of permeates the culture. Now, just to the left of that, you have the stage 2. These are the 25 people in the 100, strong organization that, oh, my life sucks. I just don't have a great boss in my life. And they come into work sort of semi-disenfranchised. They still work. They put an honest day's work in. But, they're just negative and they're not really empowered. The left here will sort of ignore. This is really the alienated minority. Mostly, people who will steal from the company, send brown envelopes, and things of that nature. But if we go on the positive side, where you really want your organization to have the majority of people is at stage 4. This is a stage where people work truly together in teams. And there's no I'm great anymore. It's we're great. This is a culture where people are really working together for the greater good. It's a little less competitive. And when people are promoted, people are proud to see their colleague being promoted. Rarely are the organizations who have the majority of their employees in stage 4. Stage 5 we can skip. You can Google that. We don't have time for that. But this is basically almost the Gandhi type of people in the organization. And there's always a few people in there, but rarely are the masses in there. So in our approach is working with small teams. What you're trying to do is move every stage, a few people from stage 2 to stage 3 and a few people from stage 3 to stage 4, and empower that process to occur so that your stage 4 category grows and all of a sudden the balance is tipped and your organization is functioning at a high rate of productivity. Here are some of the results and the source for that. And more importantly, and I know this PowerPoint can be available after the webinar, so I'll go to the next slide. Where is this relevant now to mental health? So we can look at productivity, profitability, and all of this stuff. However, let's look at what happens in a results when you sort of look at those results and see what is pertinent to mental health. And I think these speak to themselves. I recently quoted a client who had 125% turnover in 1.5 years. That is huge. I can't imagine and so he was really looking at lowering that turnover rate. And how do we do that? Well, working on the culture piece certainly helps. So folks, that brings us to an end. And while MHI is actually leveraging some technology now as we move forward, and we're going to be really happy to unveil that in the next couple of months, we certainly think that human interaction is key to moving forward. So I think we're at questions now. Thank you very much. This is really awkward because I don't see anybody's body language. So we have 10 minutes for questions.
Thank you so much, Stephane. That was wonderful. So yeah, we want to dive into some questions. I haven't seen any come up on the chat, but I do have a couple that we can certainly ask. As a reminder, please ask your questions through the chat, and we can keep going. So Stephane, first question I do have for you here. If I have an employee who is struggling or seems to be struggling, what's the best way to help?
Well, I think I alluded to that earlier on. I think the best way to help is, first of all, when you approach that individual, do not approach that individual thinking that you need to have answers and solutions. Now, if you happen to have answers and solutions, good for you. But this should not be the baseline to establish your comfort to actually engaging with that person. Just try to bring yourself back to a time where you yourself had a bad day. And I know a bad day does not compare to somebody who may have a chronic mental health condition. However, bring yourself back to a time where you weren't that great or you weren't feeling that great, and remember how it felt. And approach this person who's struggling in the workplace with some humility. Simply a caring approach, but an authentic caring approach. Don't lay it on too thick. And find a place to have a conversation and be comfortable with that. Now, of course, that's easier said than done. Not all of us are comfortable with these situations, but that is really where lies the solution. And so building a caring connection, it is the connection you will build with the person and making that person feel supported and heard, which is half the battle. So I think moving away from that solution-based approach is huge. And of course, there's a lot more that we could share on this, but that is certainly a paradigm that we have to move away from. Really, the human connection is going to be your role as a colleague or as a manager, not the clinical solution. And of course, at the end of it all, if you slip them the EAP pamphlet, that's all great, right? But don't slip them the EAP pamphlet and risk being perceived as not caring, because that perception will be a force multiplier in the wrong direction. Because now the employee will go call the EAP thinking, that person doesn't care. They just slipped me a pamphlet, right? And it's the perception that counts. So work hard at creating a reverse perception, perhaps.
So Rosemary actually added a second part to that question. Do you have any tips when it comes to approaching employees or colleagues that can help help it to feel a little less invasive?
Absolutely. So I believe that there's sort of two scenarios, right? If Rosemary, if you're in a situation today where you don't have an employee with, if you're a manager as an example and you don't happen to have any employees that way, then tomorrow I would work on a strategy to increasing your presence as a manager, as a boss, and create a new sense of a relationship with your employees, right? Where I said start early, build that relationship, that caring relationship where you know that Bob has 2 kids and one of them just left for university last year. So building that relationship ahead of time is huge. In lieu of that, if you haven't built that relationship and the person is struggling now because this is happening now, then I think, again, the approach doesn't need to be invasive, but it can be as simple as having a conversation with your own words now. These are not necessarily the words I would use, but the message you're transferring, your message you're sending the employee is essentially that, you know what, we've been working together for a few years, and I've seen you, you seem to be more isolated these days. You seem to be, I don't see you in the lunchroom as often, you've been late for a few meetings, whatever's going on, leverage that, but again, in a non-invasive way. The body language, the tone has to be appropriate, and then follow that up with, is there anything I can do to support you? And of course, if the employee is a poor performer and you were about to fire that employee, then don't pretend that that's not happening either. And so don't say you're a valued member of the team and we want to keep you around and we're worried. No, be authentic and real. And assuming this employee is doing a good job, you tell them that. And then essentially give them the power. Ask them, is there anything I can do. And by the way, I don't want to put you on the hot spot now. If you can't answer that now, that's okay. But you know, I'm going to keep asking you that because I want whatever's going on in your life. I really want you to get through this in a positive way because we need you around here, right? Again, you don't want to lay it on too thick. You want to be authentic. You want to communicate within the context of the reality and what's happening now. But again, I think it's that simple. And I'm not saying that it works 100% of the time, but it's a lot better than doing nothing. And I think it's back to authenticity and a caring approach.
Great. Thanks, Stephane. Another question for you. So the workforce is changing, and with that, there's more and more millennials coming into the workforce. And their impression of mental health and their feelings on mental health is a little bit different. Is there any way you can recommend or suggest trying to implement those mental health conversations with that changing workforce?
Yes, absolutely. And I think it goes back to something I said earlier in the webinar. Of course, as a 52-year-old, I'm not too sure I'm completely synchronized to, you know, the much younger generation and what they know and don't know about this whole affair and what they're going through. And so it goes back to the community-based rehabilitation approach. I think that engaging them in helping you, humility, I think, is something we, in the spirit of productivity and building greater workplaces and greater workforces, we sort of forgot that it's really important not to only engage our employees once a year during the engagement survey, but it's okay to engage them throughout the year and pick their brains and ask them for input, ask them for advice. There's nothing wrong with a leader or a manager asking people for advice. And I would approach that generation, the future generation, the millennium generation, in that same light. To say, listen, we're building a mental health strategy. We need the youngest people in the company to work with us to develop a way forward that has meaning, that is meaningful to you guys. So let's have the conversation. Now, when we implement any types of programs, we engage these various sectors of the workplace. And the ideal, by the way, is to find a way, and there is a way to do this, by the way, to find a way to get those in a room to engage authentically based on the fact that they know what it's like to suffer from a mental health problem. Now, you can't invite, you can't send an invitation to your workforce by saying those who suffer depression and mental illness in their lives come to the meeting. Of course, nobody's going to show up. But there are different ways you can sort of entice people to come to the meeting. And what you're doing now is you're sort of getting the insight of those very people. And that's the insight you need to build something that has meaningful impact on that very population. So again, engage them, ask them.
Okay, great. Are there any significant telltale signs of mental health issues we can look out for that are prominent enough to warrant an approach? Absolutely.
Big changes in behavior, where one employee was behaving a certain way and they're not behaving that way anymore. Of course, if you hired the person yesterday, that won't work. But assuming the person's been around for a while, that is definitely behavioral changes is definitely something to look out for. And what I really encourage people to do is, again, away from the clinical language, as much as possible, focus on behaviors, not symptoms. Symptoms are meaningful for doctors. Behaviors are meaningful for us, the people in the workforce, the bosses, the managers, the leaders.
So a couple more things here. Thank you for all the questions, everyone. Just if you do need to get in contact, you want to get in contact with Stephane, he has his book, as he mentioned, coming out next year. You can register to find out more information at stephanegrenier.com, and his email and the Mental Health Innovations website is found right there. We will be sending out this deck for everyone as well, so you can look forward to that to find out any more information. And last but not least, if you're concerned about mental health in your workplace, you can reach out to Stephane, or you can come and speak with us here at League. We sort of went over off the top. Our spending accounts can empower your team and your manager to deal with mental health, to look into their mental health in the ways that they would like. Our Health at Work would let you bring health professionals into your office to address mental health in new and unique ways. You know, if you want to bring in a meditation session or a yoga class or something like that, all of those things can work really well. And last but not least, our Peace of Mind plan is insurance that would include employee assistance programs for your team and things like that. So once again, really want to thank everyone for attending today. Stephane, thank you so much for the wonderful presentation. It was great. And you will be hearing from us, everyone who attended. We will be sending out this video as well as the slide deck. And thanks again for attending.